Okay, it's 2 p.m. in Singapore on Wednesday, 26 January 2022. I'd like to welcome all of you to this webinar hosted by the SingHealth Duke-NUS Global Health Institute in Singapore. I'm Amina Mahmood, Deputy Director of the Institute, and it's great to have you all in this discussion. We're going to talk about the transformation of Singapore's healthcare system by Dr. Edwin Low. And this talk is part of our monthly Global Health Seminar series, during which we raise topics of global health importance and relevance both to our communities here in Singapore and the region. And we really like this audience to be as diverse as possible, and we welcome everyone to these discussions. Thank you, Edwin, for sharing your story with us. And a quick introduction for those who don't know him. Dr. Low is currently Director, Program Development, SingHealth Office of Regional Health, and he's also faculty with our institute. Concurrently, he is a fellow at the Healthcare Leadership College. He also oversees external operations for COVID-19. Prior to his current appointment, he held group director positions in regional health system, academic medicine, and strategic human resources in SingHealth. He was also the inaugural executive director of the National Medical Research Council in the years 2006 to 2010. Prior to joining SingHealth, Dr. Low served for more than 20 years in the Singapore Armed Forces, where he last served as the Chief Naval Medical Officer. So he brings all this expertise and applies it to Singapore's transformation. And we also will talk to him about some of the regional implications that this might have. Before I hand over to him, a few housekeeping notes. Please keep yourselves on silent. This webinar is being recorded, and we'll address questions at the end. You can post them at any time in the chat box, and we kind of go through them once he's finished his presentation. Thank you for those who have already posted some questions. We'll be looking at those too. Thank you, and over to you, Edwin.
Thank you, Amina, for your very kind introduction and invitation to share for this afternoon's topic. Just a quick check, you're hearing me okay?
Yes.
Okay, thanks. So good afternoon to everybody. For this afternoon, for my presentation, I'll be sharing about Singapore's healthcare system transformation over the last 50 years. And then we'll look at the question of whether some of our successes can be replicated, and also whether we can even learn from our neighbors. So just want to have a caveat that what I will not be covering in my presentation will be anything to do with healthcare financing and healthcare IT. I think that would be far too much to bite off. So in the first part of my presentation, I'll talk about the early years, some of the key healthcare policies that have shaped our current system, as well as the changes in our healthcare landscape since independence. And after that, we'll consider some of the challenges that will shape our healthcare system going into the future. And lastly, we'll see if Singapore, as a little red dot in the region, will we be able to contribute to healthcare improvement in the ASEAN region. So let's begin in the early years of our independence. What were the challenges facing our young nation? The major public health concerns at that time were largely communicable diseases. For example, polio, TB, and waterborne diseases like cholera, typhoid, and dysentery. You hardly hear about them these days. There were also issues of malnutrition, sanitation, and clean water, as well as housing. So as such, in the 60s and in the 70s, the key healthcare policies were really around clean water and sanitation. For the sanitation here, you can see our what we call our night soil carriers. They were actually collecting waste from these kind of toilets, outhouses. The waste was often recycled as fertilizer, so you could actually say that we had organic farming even 5 decades ago, since we didn't use any chemical fertilizers then. Now, infectious diseases was a scourge in our early nationhood. I'm not sure how many of you have seen the effects of polio. In its worst manifestation, there is respiratory muscle paralysis, and you require an iron lung to assist your ventilation, as you see here. More commonly, there will be muscle wasting of the lower limb, and you can see this is kind of gait that you will have for the rest of your life from childhood. I had 2 personal friends, one in junior college and one in medical school, who were affected. Thankfully, the last case of polio was reported in 1978. Besides polio, there was tuberculosis, and this was a major cause of death in the 1940s. In 1959, the year that I was born, okay, that's open secret now, the prevalence of TB was 3.7. And today's prevalence is around 39 cases per 100,000, or 0.039%, which is a 100-fold decrease. So what did we do then to bring down the disease prevalence? Well, we implemented massive surveillance programs via mobile X-ray buses like this, and mass vaccination for the population. And talking about mobile buses, let's fast forward 5 decades. We still have mobile buses today as part of Singapore's healthcare system. Here you can see NHG's fleet of buses that can do mammogram, chest x-ray, even bone mineral density. NUHS has its mobile hearing bus that does audiometry. And SingHealth, of course, not to be left out, we have our own iBus. And interestingly, both the hearing and the iBus have been called to service in a recent program called the Project Silver Screen. This is a functional screening program for eyes, ears and teeth in the seniors. Okay, contributing to communicable diseases, we also had the problem of poor hygiene. Now, our founding Prime Minister, Mr. Lee, in launching the Keep Singapore Clean campaign in 1968, he made a link between health and economic growth. He said, good hygiene will essentially help keep morale high, sickness rate low, and so create the necessary social conditions for higher economic growth in industry and in tourism. But why was there a need to have a Keep Singapore Clean campaign? Well, because in the 1960s, hygiene in Singapore was bad, very bad. So the padang wasn't always clean as it was today. Here you can see bullock carts. Long before there were contingents lined up for parades, there were these creatures on the padang. And so the government declared war and set up a high-level advisory committee, as you can see here. And it also mobilized a 1,500-strong emergency cleansing corps. Now, fast forward to 2016. Again, we proclaimed war. This time, again, diabetes. And here we have an interministerial diabetes task force. It's chaired by Minister for Health and for Minister for Education. So I think you can begin to see a trend here in our healthcare. When there are complex problems facing the country, we like to form high-level inter-ministry task force or whole-of-government committees. And the multi-ministry task force for COVID is a very recent example. Besides infectious diseases, the other major challenge in the early years was malnutrition, and this was widespread in post-war Singapore. Babies were often fed condensed milk, none of the fortified milk formulas that we have these days. Okay, this is where I get to tell a grandfather's story, okay? When I was a kid, I was one of the many underweight children. So every couple of days, my father used to cut slices of butter and stick a toothpick in it, and I had to eat it just like an ice cream, and that was just to really fatten me up. I know many of you might think this is gross, but it's actually not half bad, and I grew to like it, the salted butter, and that probably explains my current love for kaya toast with butter today. Then in 1974, the school milk program was launched. In 1974, I was already in my teens, so I missed the boat, and thank goodness for that. Otherwise, I might have become like one of these kids. So yes, there were a number of policies that have unintended consequences. And I think we can easily think of other such policies, for example, the stop at 2 family planning policy that we had in the 1970s. And we move on now to how was healthcare delivered? Well, in the early years, I'd like to start off again with our nursing heroes. And here in this montage, you can see in the 50s, we had our kampong nurses or village nurses. They would ply the countryside. They would even take a boat to offshore islands like Pulau Ubin or Sentosa to provide much needed antenatal and postnatal care, vaccination and health education as well. So antenatal care by these really wonderful nurses provided a very important means to keep, or rather to reduce our maternal and infant mortality rates. And besides these community nurses who were applying all of Singapore and offshore islands, there were also the nurses who were stationed in the community facilities. Like here we have an example of a maternal, Bukit Panjang Maternal and Child Health Centre. But again, with the shift of population in the 70s to HDB townships, then a maternal child health clinic like this one and outpatient dispensary like this quickly became a very nice, well, then spanking new polyclinic. And here you can see the Queenstown Polyclinic back in the 70s. And by 1978, all the outpatient dispensaries were merged with the maternal child health clinics. And I think in 1979, Bedok, Clementi, and Bukit Merah polyclinics were established. Then how about our hospitals? Well, there were 2 general hospitals in the 1960s. There was the General Hospital Outram Road that later became the Singapore General Hospital. And there was a Thomson Road Hospital that later became the Toa Payoh Hospital, and then later moved and became the Changi General Hospital. Here you have this famous hospital, the Kalang Kebal Hospital. In 1966, it saw something like 39,856 deliveries and actually entered the Guinness Book of Records for having the largest number of births in a single maternity facility in the world. Interestingly, in this slide, you can see that political correctness wasn't a big thing. From the names of the hospitals you see here, like the mental defective hospital and the chronic sick hospital. I'm not sure anybody would be willing today to be admitted into such a hospital. So then, who were our healthcare heroes in the early years that brought our healthcare standards up? Was it the Ministry of Health, or perhaps these other agencies like URA, like utilities that provided sanitation and clean water, or HDB that provided a roof over our heads? Truth be told, I think most of you know the contribution to health from healthcare is at best 20%, depending on what you read. And just a note about health and wealth again, in 1964, at the start of the Clean Singapore campaign that I showed you earlier, the GDP was only $8.5 billion. In 1993, it was $50 billion. The GDP in 2020, it was down a little bit from because of the COVID, was Singapore dollars $450 billion. That's a 57-fold increase over a 55-year period. So in a way, it adds another dimension to the health is wealth at the macro level. And indeed, good health for a nation is necessary if you want to have good economic growth. Okay, now we'll move on to what are the major milestones in the last policy milestones in the last 50 years. This slide shows you a very kind of a sample overview of the major healthcare policies that have shaped our healthcare system today. This list is by no means exhaustive, and I'll just run through the main ones in the next few slides. The first comprehensive healthcare plan was written in 1983. There were 4 pillars, and interestingly, you can see that the problem of the aging population was already foreseen back in 1983. Talk about forward planning by the government. There's this quote here from a report on affordable excellence, and it remarked that Singapore began focusing on disease prevention through a healthy lifestyle along with screening for as well as optimal treatment of disease. And in this respect, we were well in advance of other countries that only started to shift their emphasis to chronic diseases around 2010 or so. So I think this is really a testimony to the foresight of the government in the early 80s. Then in 1993, there was a landmark affordable healthcare white paper that was submitted by then DPM Lee Hsien Loong, and he really outlined 5 major pillars. The first was to become a healthy nation by promoting good health. Second, to promote individual responsibility for one's health, to avoid over-reliance on state welfare or third-party medical insurance, to ensure good, affordable, basic medical services for all Singaporeans, and then engaging competition and market forces to improve delivery and raise efficiency. We'll see how that affected our clustering later on. And then intervening directly in the healthcare sector where necessary, when the market fails to keep the healthcare costs down. Then in 2011, the Primary Care Master Plan expanded the reach of portable subsidies for Singaporeans and roped in the GP community to help with the management of chronic diseases. Prior to 2011, there was this PCPS, or the Primary Care Partnership Scheme, which allowed for portable subsidies for care at GPs instead of polyclinics. Then in 2011, by raising the qualifying income for the PCPS from $800 to about $1,500 per capita monthly household income, and at the same time lowering the age criteria for eligibility from 65 to 40 years old, the pool of patients who were covered by the new PCPS scheme increased by a factor of 20-fold. So about 710,000 people were now covered. Then in January 2014, the qualifying age for CHAS, the PCS became renamed CHAS in 2012. So the qualifying age for the CHAS, which was 40 years and above, was removed. So this basically enabled all Singaporeans in the lower and middle income households to access subsidized medical and dental care at over 800 private clinics at that time. And then also to support the GPs, the MOH established what we call the community health centers, and these facilities were located in the heartlands, and you were able to do things like diabetic foot screening, retinal photography, and health counseling as well. Today, there are over 2,000 or close to 2,000 medical and dental clinics that accept these various CHAS subsidy schemes. Then we had Healthcare 2020, which revolved around accessibility, affordability, and good health, quality care. But I think you know what they say, right? It's not always achievable to get all three. And I used to think so, but I actually found one very good example in healthcare that is actually fast, cheap, and good. And if you have time, I'll talk about it at the end or perhaps during the Q&A session if anyone's interested. So typically good and cheap is what we consider as a public subsidized care. We just have to wait for some of our new appointments. Good and fast, I think really it's a private healthcare system, but it can be very expensive. If it's fast and cheap and it's in healthcare, we probably all want to stay away from that one because likely, it's not good. And in 2014, the Healthy Living Master Plan was launched, and that incorporated basically 3 dimensions. The first was integrating physical and social environments in the community. The second was creating greater awareness for healthy living amongst the young. And the third was building a central healthy workplace ecosystem. But I think the central tenet was to enhance access to health promoting programs, amenities or eateries, either in the workplace or in the community. Then here we are today at the current plan, which is Beyond Healthcare 2020. I'm sure all of you are familiar with this, for the Singaporeans especially. We're talking about really moving care beyond hospital to the community, and beyond quality to value, and also beyond healthcare to health. And I guess I'm being a little bit cheeky here, but I'll say that we probably also want to look at moving our healthcare, from this generation to next. And what do I mean by this? Really looking at early childhood and maybe even more upstream to antenatal period to ensure that the next generation get off to a good start for a healthy life. So I'll kind of stop here in the sense that, budget speech and the Committee of Supply speeches are just around the corner in February and March. Certainly recommend that you tune in for the latest direction from MOH, and I won't say any more lest I inadvertently say something I shouldn't be saying and then I run afoul of the Official Secrets Act. So I'm going to move on now to the healthcare landscape. Right, so let's look at the transformation of our healthcare landscape in Singapore. I alluded to some of the healthcare infrastructure in the early years, the polyclinics that were formed from the maternal child health clinics and OPDs, outpatient dispensaries. So I'll move on to a little bit more macro level. In the 1980s, basically we had the corporatization of the public sector hospitals. So the Healthcare Corporation of Singapore was the company or the holding company that was created in 1987 for all the restructured hospitals. Incidentally, HCS later became the current Ministry of Health Holdings or MOHH, which today holds key functions like information technology, medical manpower, and internal audit. Then in 2000, public healthcare sector was divided into 2, the SingHealth and the National Healthcare Group. And this was really to promote the vertical integration of care and introduce some level of competition to provide quality care. But I think, as you know, for some of us who were in the system, this competition, I think, had also, again, unintended consequences, like basically now having, that time, 2 IT systems and therefore having to introduce the NEHR to allow the 2 IT systems to talk to each other. And then in 2007 and 2008, MOH saw an opportunity to restructure healthcare institutions with the promise of working with providers in the community to provide patient-centered care. And so this resulted in the formation of 6 clusters, and they were called the regional health systems. By 2018, we had become 3 clusters, I think you know that, and the question on many people's minds was, would we recluster yet again? And this is what Minister Ong had to say at the 2021 MOH Work Plan. We should not review the structure of our clusters, and we should continue with the structures that we have. And it was even reported in the press, in the media, that there will be no further review of the 3-cluster healthcare system, ending any speculation of more changes in the near future. Now, beyond healthcare institutions, there were other significant changes in recent years in the healthcare scene. The first was the Silver Generation Office. And this basically moved from the People's Association under the Ministry of Community, Culture and Youth to the Agency for Integrated Care under MOHH. And thanks to that, MOH now has help for more than 3,000 plus Silver Generation ambassadors who can support the social dimensions of health for the seniors. Now, so besides explaining government policies, these ambassadors, volunteers, they will help with functional screening for seniors. On a day-to-day basis, they will visit seniors. They will help connect them to either active aging programs or befrienders, or if necessary, to a community nurse for care and support. Now, I talked about the community nurses earlier on in our early years. MOH reintroduced the community nurses back in 2017, and already they are making a huge impact in the transition of care from hospital to home, as well as in preventive health programs. And then finally, as part of the strategic shift to move care beyond the hospital to the community in 2018, the ministry introduced what we call the primary care networks, or PCNs. And this is a new framework to help the GPs self-organize into groups to provide better care for chronic diseases, with support from the much needed ancillary services like dietary counselling, diabetic food screening, and so on, through the community health centres that I spoke about in the earlier slide. And at this point, I'd like to just take a pause, because in a sense, whatever you want to say, the COVID pandemic, that's what it's done to us. It's forced us to take a kind of a pause. And there were many changes that were brought by the onslaught of COVID. So you remember the crisis that we had in April 2020, when we started to have migrant worker outbreaks in the dormitories. And during the circuit breaker, the healthcare clusters mobilized hundreds of staff to help provide support to the dormitories, because the workers were all kind of holed up inside the dormitories. But with the return to BAU, our staff had to go back to work, and the private healthcare then stepped up and they provided regional support like this to a lot of the dormitories, all the dormitories. And today, none of the clusters provide that support. At the height of the dormitory outbreak, the private sector also helped to run the mega facilities like this one here at the Changi Exhibition Centre. And this was like about 2,000 or 3,000 odd dormitory workers that could be housed here. And this was run by Raffles Medical Group. And then later on in the 2020, when vaccines became available, the private sector again played a critical role. Almost all, if not the mega vaccination centres, were operated by private sector, and this could run up to 1,000 odd vaccinations per day. Then in terms of community care facilities, we used to have up to mid-2020, we used to have only one type, just CCF. But over the period from August 21 to October 21, we had to deal with the Delta surge. And we dramatically increased capacity and expanded here, you can see from here, these few numbers, to this large number of facilities. And we also differentiated the type of facilities. So now, today, we have what we call the Community Isolation Facility, or CIF. These are hotel facilities for those who can't do home recovery programs. Then we have the CIF Medical, which has a small on-site medical team. And most recently, we have the COVID treatment facilities, which are run out of various sites, including some unused wards. So there's no doubt that this pandemic is going to leave an indelible mark on our healthcare system. And to be honest, I really dare not hazard a guess which of these facilities in its current form or some future form there will be in the years to come. But I mention this because I think just to highlight that most of these facilities are run by our private sector colleagues, and I suspect that these new partnerships between our public and our private sector will be here to stay, and I really think that's really a good thing. Okay, I'm going to move on now to the future of Singapore's healthcare. What about our future? Now, since I'm no economist, I'm just going to use a very simple demand-supply framework for our discussion. On the demand side, I'll just talk about two: chronic disease and aging. And on the supply side, we'll be looking at money and manpower. So, normally in a face-to-face class, I would ask you to look to a person to your right and the person to your left, and then ask the three of you to say to each other, one of us is going to get diabetes by 2050. With Zoom classes, I can't do that. So now I just ask folks to look at the image on your right and the image on your left and say to yourself, one of us is going to get diabetes. But I think in this webinar, you can't even see each other, so we can't do that. But Singapore is not alone in this problem. The International Diabetes Federation reported here in 2015 that over half of the people with diabetes were living in the Southeast Asian region or the Western Pacific region. And here you can see the projected rise in type 2 diabetes in our region, and you can see here it's really quite frightening. We talked about aging, and besides the chronic diseases, we also need to think about dementia and frailty. And here are some sobering statistics. By the time you're age 80, about 1 in 4 of our seniors will have either dementia or frailty or both. But it's not all doom and gloom. On aging, I'd like to leave you with a positive note, especially since I'm a senior. I leave you with a quote from our senior Minister of State, Amy Khor. She said, aging is not necessarily a burden. because of medical advancements, diet, good health, and so on. And here in this slide, you can see very nice examples of seniors who are very active physically as well as active mentally as well. Now over to the supply side. Just notice the grim look from our previous Minister for Health, Mr. Gan, as he tells us that the rate of healthcare spending is unsustainable. And on the right, you can see why. He's looking at a projected six-fold increase in healthcare expenditure nationally between 2010 and 2030. So no wonder he looks grim. But wait a minute, you might be asking, so why can't a country with one of the highest GDP per capita afford the projected rise in healthcare costs? Well, here's another way of looking at it, and this is a quote from our Prime Minister Lee. First, he said the same thing as Minister for Health in last year's Work Plan speech, that healthcare is both an emotive and a political issue. That's number one. And then he said, very importantly, that it's important for the government to present the full facts and the trade-offs, because every dollar that is spent on healthcare is $1 taken from the taxpayers and $1 less to be spent elsewhere, whether it's education, housing, defense, or the personal needs of our people. That's really food for thought. And it's not just about the money, it's about the warm bodies. Can we get enough staff locally? You know that there have been many mid-career streams that have been launched, and the intake of nurses, doctors, and allied health has increased. But there are also departures, as you heard last year, and every healthcare worker that you recruit is one less for the rest of the economy. And it's something to think about if you remember PM's quote in the last slide. And just to underscore the point, here's a couple of media stories, just last year's media press, that underscores our pressing manpower situations. We have nursing students being tapped to supplement the healthcare force, and all these statements about even getting a finder's fee to try to recruit nurses. And just to highlight that the healthcare worker shortage is global, we must be aware that as much as Singapore has drawn overseas nurses from our region, so countries like US, UK, Australia, they are also on the hunt for nurses. And they could be well drawing from the nurses from our shores as well. And this is just some recent media articles from last year from Australia, where they're trying to recruit thousands as well to their shores. Now, nationally, coming back to Singapore, it doesn't help that our population is shrinking either. And just look at the headlines. Singapore population grows at the slowest rate since 1965. And fewer Singaporeans are marrying and having children. And then in just last October of last year, MOH announced that they need 7 more nursing homes to be built, to basically help look after seniors like myself. So then, what does the government think that we need to do? And I would say it's probably 2 things really, and that's innovate and to increase productivity. So if you look at this slide, someone did a count of the number of times productivity was mentioned in budget statements, and this is only up to 2010, and it's gone up by many times since then. Why do I say that? Look at these reports. First, we have slipped in our competitiveness because of many things, in one of them being the lack of productivity. And in this other article, you can see that in both labour and total productivity, we are underperforming relative to our trading partners, to our peers, and the OECD countries. So this is worrisome. Thankfully, the government has put money where its mouth is. It's invested for innovation, and it's done so for healthcare as well. So we've got our own money for innovation. And again, thankfully, the clusters have taken this imperative seriously, and each of the clusters have set up their enabling structures to spur innovation and to increase productivity. So on that note, I'd like to move on to this question now of what can Singapore contribute to the health of this region that we call ASEAN. After all, we were once famously told that we're just a little red dot. And indeed we are. So by way of background, ASEAN was formed back in August of 1967 with the signing of the ASEAN Declaration by the 5 founding members. That was Indonesia, Malaysia, Philippines, Singapore, and Thailand, also known as the ASEAN 5. Interestingly, Kishore Mahabuni, as you can see in this quote here, he was a former Singaporean ambassador to the United Nations, declared, when ASEAN, the Association for Southeast Asian Nations, was born on 8th of August 1967, it was destined to fail. And you can see why. After all, Southeast Asia was and continues to be one of the most diverse regions in the world. It has 4 major religions, 800 odd languages, multiple ethnicities, and radically different um, political systems as well. At that time, ASEAN was formed because of this communist threat that was feared. At the time, Vietnam had just turned communist from China's influence, and we were all worried about this domino theory. And so one of the reasons was actually a kind of a defense reason as well. Then you fast forward 5 decades, despite our unprecedented diversity that I showed you earlier, ASEAN actually brought quite a durable stability and prosperity to more than 650 million people in Southeast Asia. Collectively, ASEAN will grow to be the world's 5th largest economy and the 3rd largest recipient of foreign investment. And notwithstanding the inclusion of low-income members and the onslaught of the Asian financial crisis in the late 1990s, the ASEAN per capita GDP has crossed $4,000 in 2016. That's 33 times the level in 1967 when it was only $122. So as a consequence, today only 14% of ASEAN's population are estimated to living below the poverty line when last assessed in 2015, as compared to nearly half the population in 1990. So certainly we're making good progress. Now, still on diversity, in ASEAN, 43% of the region's population live in urban areas, but there's a lot of variation, right? From 15% in Cambodia to something like 100% in Singapore. Population densities also range widely from a low of 27 people per square kilometer in Laos to 7,022 per square kilometer in Singapore. And demographic transition is also taking place at the fastest rate compared to other regions in the world, whether in terms of fertility reductions, population aging, or even rural to urban migration. Epidemiological transition in terms of diseases is also shifting, with disease burdens moving from infectious to chronic diseases, and I think I showed that earlier on. Interestingly, the other thing is Southeast Asia's peculiar geology. It actually contributes it to being one of the most disaster-prone regions in the world. So you have earthquakes, typhoons, floods, and environmental pollution. Philippines and Indonesia are rather unfortunate because they are located in what we call the Pacific Ring of Fire, a zone of earthquakes and 41 volcanoes with something like 90% of the world's earthquakes occur. And we all remember the Indian Ocean earthquake just off the coast of Sumatra in 2004. That caused a massive tsunami that affected countries as far as Sri Lanka and Thailand. And although Singapore has been relatively blessed with a safe location from natural disasters, we can still be indirectly affected by disasters in neighboring countries, right? Many of us recollect the haze that was in Kalimantan and Sumatra not that long ago when we were blanketed as well. Still on diversity, in the area of GDP per capita, which is a proxy of living standard, here you can see Singapore at the highest value in 2019 was about US $65,000 and US $29,000 for Brunei. These figures were like something at 13.5 and 6.5 times the ASEAN average here of about US $4,800. So there's quite a lot of diversity. And another way of looking at it is the Human Development Index. What is this about? The HDI is a measure of the well-being of a country's population. It focuses on 3 things: the ability to lead a long and healthy life as measured by life expectancy at birth, the ability to acquire knowledge as measured by the mean years of schooling and expected years of schooling, the ability to achieve a decent standard of living as measured by gross national income per capita. And here on this chart you can see that it's quite a variable. Another way of looking at it is if you plot the educational status, which is gross tertiary enrollment, against the health status for which is under 5 mortality rate per 1,000 live births. Here you can see again Singapore, Thailand are doing well here, whereas the rest of the country are quite spread out as well. So then on health statistics, you can see again here there's quite a bit of a difference for under 5 mortality here, ranging from 2.4 in Singapore to 60 something in Laos. Right, life expectancy at birth, also quite a bit of difference, although it's been closing. The gap has been closing quite nicely over the last few years. In terms of immunization, here for measles, which is a major cause of mortality in children, you can see that actually there's still quite a wide variation in the countries. Now then, education. Beyond health indices, we need to look at the social factors like education. Now we already know in older age, lower education and geographical factors, they all act as barriers to access. So the inability to read and understand health-related information, even in absence of language barriers, can already lead to inadequate health literacy. And older adults and those with lower education are also unlikely to use sophisticated platforms, apps, for example, for accessing health-related information. So across ASEAN, if you look at it, the primary education enrollment is pretty healthy, actually. But in terms of secondary education, it drops quite a lot. And so this is an area for concern in terms of health literacy, which is obviously going to play a major impact on health in the individual. We talked about how important clean water and sanitation was, improving the health of Singaporeans in our early years. And you can see from this slide in terms of access to drinking water here and sanitation, there's still quite a lot of countries that don't have the good access to safe drinking water and improved sanitation. There's been a lot of improvement, to be fair, over the years, as you can see here, from 27 to 74, but it's still not really up to scratch yet. Interestingly, here's an article from Straits Times which reported 2 weeks ago about a Singaporean company that created the device that helps bring potable water to rural communities. So I guess Singapore is somehow playing a small role even in the important area of clean water, not just health. Then demographics. So I talked a little bit about it. Decreased fertility has been a major contribution to aging in the ASEAN countries. So all the countries in ASEAN are aging, as from this report from the United Nations. And a lot of the older persons also spend a fair amount of years with impairments. So it's not just a life expectancy, it's a healthy life expectancy that we're more interested in. The most significant increases actually was found in Singapore and Thailand. As you can see, 7.2, 9.1 to 14.4 and 12.5 from 2000 to 2019. And Singapore, as you well know, is now ranked as one of the countries with the lowest ultra low fertility. So hopefully, as we tackle the challenge of aging population, both Singapore and Thailand can learn from each other what we are trying to do. So against this backdrop of such diversity, I guess the question is, can some of our successes be replicated? Or is there even a demand for interest from the region? Well, today, just to share with you, the SingHealth Duke-NUS Global Health Institute accounts some 134 global health projects, with 89 of them active. And interestingly, many of these projects actually arose from requests from our neighbours through our International Collaboration Office before the SDGHI was formed. Today, we have 43 partnerships in 15 countries that are reflected by formal partnerships, agreements, or MOUs. So I guess in conclusion, I would say I do think there's a place and role for us to be able to share some of our successes. And conversely, there's also much that we can learn in terms of other countries. I'll give you an example of Thailand, for example. And certainly in areas of disease, communicable disease like disease X that we're also worried about, we need to collaborate much more closely with not only ASEAN, but also North and South Asia as well. I have a little bit of time, Amina, so I'm just going to share with you something that I spoke about. When I talk about cheap, fast, and good healthcare, earlier I mentioned to you that I was kind of thinking that it's probably not possible, but I was wrong. I'm not sure if you have heard of this healthcare group. Narayana Health is a chain of 21 hospitals and 6 heart centers across 18 cities in India and 1 in the Cayman Islands. So in 2001, this gentleman here, Dr. David Shetty, is a cardiac surgeon. He set up a 280-bed heart hospital called Narayana Hudayalaya. And he provided some of the lowest cost heart surgeries available in the country through economies of scale. He was in fact nicknamed the Henry Ford of heart surgery because he applied mass production techniques to healthcare, like standardizing procedures, exploiting economies of scale. And a high degree of standardization for every procedure actually also helped to ensure patient safety. So what this gentleman actually did was essentially he translated business model innovation from one sector to another, and in this case, it was the core innovation of mass production. So the success in bringing complex heart surgery to needy patients is often cited as a role model in many reports that you can see here, like Wharton Business School and the Commonwealth Fund and so on. It's really a model for accessible, affordable healthcare. And interestingly, there's another article from the BMJ that actually said that cardiac surgeons in training, from the UK at least, they could get far more training hands-on in the Narayana Health Centers compared to training hospitals in the US, in the UK, I mean. And in 2014, Narayana Health opened the Health City Cayman Islands, or HCCI, and brought its innovative practices that they honed in India right to the doorstep of the US. So this 105-bedded super specialty hospital was able to provide first-rate care at 25 to 40% of US prices. And despite the low prices, the HCCI's outcomes were excellent. They had a mortality rate of 0, which is truly value-based care. And they were accredited by the JCI International and had a glowing patient testimonials as well. So how did they do it? They achieved ultra-low prices by adopting many of the frugal practices that they transferred from India. And this is really a good example of health innovation, reverse innovation. So the hospital was built at a cost of around 700,000 per bed, compared to about 2 million per bed in the US. And they had, for example, open bay intensive care units, which basically optimized the space and required fewer nurses to be on duty. They leveraged essentially relations with its suppliers back in India, where they enjoyed much lower prices because of volume discounts. So we managed to do this so that all the FDA-approved medicines, for example, were purchased at 1/10 the price of the medicines in the US. And likewise, equipment could be bought for 1/3 or about half as much as it cost in the US. And HCCI also outsourced a lot of its back office operations, things like HR, accounting, finance, and even medical transcription and radiology. These were all done by low-cost but very highly skilled employees back in India. HCCI also then brought the high-performing doctors from India and transferred them to HCCI. So these doctors were full-time employees. They were on fixed salary. They would not allow any perverse incentives to perform unnecessary tests or procedures. The doctors were paid something at 70% of US salary levels. And lastly, they saved costs through intelligent make versus buy decisions. For example, they made their own oxygen instead of importing it from the US at a high cost. And they saved like 40% of the energy by building up a solar farm as well. So it is possible, and I think there are examples like this that we can continue to look for and learn from, as well as even as we try to impart whatever successes we have to others, we probably want to do the same and learn from others as well. On that note, thank you for your attention. I'm happy to take any questions.
Great. Edwin, thank you so much for that very fascinating journey. You managed to cover a lot of time over the span of years in talking about the transformation of Singapore's healthcare. And I certainly have some questions of how some of the lessons we can apply in the region. And I love this last example that you did have time to go through, because that's certainly something that we are interested in. But first, I'll turn to some questions we've received from the audience. In fact, they sent this in when they registered. And the one that really stands out to me is because it really kind of goes even a little bit beyond some of the topics you talked about. And it asks you, how experienced is Singapore in terms of patient engagement by technology, especially to manage chronic diseases?
Well, okay, I did say I was gonna stay away from technology because that's a really a wide field. But I would say that in terms of patient engagement with technology, I guess at one stage we were very worried about our seniors who really are the ones who need more face-to-face. So today, obviously, if you look at a wider population, a lot of us are wearing wearables and we're using apps. And that's a form of engagement. We have the ability to give patient nudges through data that is collected from wearables and so on. So that's one level of so-called patient engagement through IT. Then at a higher level where you're talking about teleconsults and so on, right? That's where, yes, I think the COVID again accelerated that quite a bit. So today you have a lot of teleconsult providers that are able to settle patients' acute conditions very quickly. But we are also, because of the COVID situation, shifting quite a lot of our follow-up patient visits, for example, onto the IT platform, teleconsults. But that has an issue because not everybody has access to the IT platforms necessary. Not everybody is familiar using the systems, and generally there's this whole issue of change management for a lot of people, not just the seniors. But the seniors are the ones that we kind of were worried about. The pioneer generation are not particularly savvy with IT, but some are. The Merdeka generation, actually, that's kind of my generation. I'm a little bit more hopeful because as I look around at my peers, many of us are on IT platforms, multiple types of platforms, whether it's health or for some of my friends, even gaming, for example, whatever it is. So we're a little bit more savvy, and I think the penetration, therefore, of health, technology, apps, and so on will become more and more widespread in time to come. I think this is something where possibly I would say that other countries, and I do believe I've read some in Africa, that they actually use, because of the spread of the geography, they actually have to use teleconsults widely and very successfully as well. Yeah, I hope that kind of answers the question, but
Yes, I think that does address some of the issues, and certainly, as you're saying, it's not only COVID, but other forms of necessity sometimes makes sure that we do use technology. So it is heartening to know that. Another question that we have, and I'm going to kind of go through these questions we've received from the audience because they're more Singapore-based, and then go to the slightly more regional ones. But this is a question that says, can we reduce the life expectancy gap based on socioeconomic status, which is highlighted by Mr. Gan in Parliament on 16 Feb 2021.
Yeah, so I did mention it that while the life expectancy at birth is gone up, the healthy life years actually hasn't gone up as much as we would like. So we're spending something like 9 to 11 years, and I'm just saying this for a range for Singapore that we have to deal with. That means the last 9 to 10 years of our life are not spent in good health. What is the role of the social interventions for these to helping them to live healthily? Actually, I would say that there's two components. One component is actually a lot to do with the upstream measures. If you want to intervene either on a social basis or on a health basis, these interventions should really be put up front to people even as early as the 40s, that you really start to take care of them in terms of their social as well as their physical health and even mental health. Because by the time you hit the last 10 years of their life, that's really the end stage of their ill health. They are already burnt out. They are already either bedridden, or they already have a disability from stroke and so on. And really what you want to be able to influence the preventable factors up early, whether they are health, physical or social factors. And that's where I think, yes, we have got a lot to do. I do believe there will be quite a lot more effort, as it is already. The ministry, as in the 3 Beyonds, talked about moving beyond healthcare to health. And over the last few years in the current healthcare plan, we have been moving progressively to try to shift healthcare efforts to promoting health in the people who are in the age 40s and so on, and even actually going one step earlier to even the children and adolescents as well, so that they're educated to live healthily.
And actually, your answer, focusing on this kind of life cycle approach, brings me to the question that I kept coming to my mind when you were presenting. You pointed out all the environmental, the sanitation, the hygiene, all the kind of surrounding factors that led to this increase in health status, the increase in life expectancy for Singapore. And of course, that was enabled by a very rapid economic growth. What are the lessons, or how can we think about that model when we are thinking of our regional countries, which are maybe not at the same level of rapid economic development, although they are all in that, definitely, but maybe not as rapid as Singapore went. And then they have to simultaneously have that whole environment that will enable the health status to be improved. So, like, how do they toggle between, the demands of the environment, which still might not be at the level that they need to be, and building a health system which is enabling a better health outcome?
Yeah. So I think just now in some of the data that I showed, obviously some of these countries have a lot of rural communities where access to water is really a problem, including sanitation. It's not an easy problem. I remember doing one of my site visits to Indonesia, where the government or the county basically tried to improve sanitation. So they built a lot of toilets, very nice toilets and everything else, but found out that the usage was actually very low. And it had to do with the people who basically were just not happy to have to go very far, for example, to do their toileting needs. And they much rather just continue with their practice, which is far more convenient, right? So I think when you try to introduce some of these things, it really is a challenging, complex problem. You have to deal with the geography, the logistics, and so on. And I, really sympathize with those governments that have to deal with that, because it's very expensive, obviously, to do some of these things. That's why I was quite encouraged when I saw that news clip about a Singaporean company that was helping to get potable water. And it's not just that small device that you saw from the gentleman trying to draw water from a stream. They actually have a more commercial, a more larger capacity one that can take up to 100 people, for example. So you could actually have a system within a village that allows you to get really clean drinking water. And clean drinking water immediately is going to help a lot with things like infant mortality and all those kind of issues, and all the communicable diseases like cholera and so on. So dealing with those problems is pretty essential. I obviously cannot offer a solution or any advice on this matter, but whether or not you can concurrently do other things to improve health. For example, while they are continuing to work on improving clean water supply and sanitation, for example, this thing about community nurses, or another example of, I believe it's Bangladesh, where basically they had a program where they brought lay people, and they trained all of them up to essentially do one simple thing, and that's to how to create oral rehydration salts. So they were taught how to mix it up and then do it. So every time the child had those diarrheal diseases, they would be given these oral replacement solutions, and that apparently was so successful and helped to reduce the infant and child mortality rate by significantly. So I think measures like this in different areas, different countries, can be adopted simultaneously, so that you kind of ramp things up a little bit faster. And of course, today with technology, to be very honest, while we may not have landlines anymore, it is quite surprising. Many countries have actually a high penetration of handphone use. And then the question is whether the handphone and apps or whatever this can be used to really reach out and provide some form of health consultation to those folks in the far-flung rural communities.
Right. Yeah, and I think your slide where you had kind of shown it's not just Ministry of Health, but it's all the other ministries that are all working together is very kind of illustrative, that how this has to be a multidisciplinary approach. So, as you said, no easy solutions, but at least some possible ways of working that can be looked at. Another point I wanted to kind of again extrapolate from the Singapore story to the region is you talked about the development of the primary care sector in Singapore, and it was obviously given a lot of attention. You pointed out from 2011. It's a decade later. It's still an evolving story. I know the Singapore primary care system is still being tweaked, and it's good. It's like things should never be taken for granted. But what are some of the lessons maybe that can be learned from, again, the regional countries? Can they leapfrog some things by, seeing how it was done in Singapore or other such countries? Especially the issues that you've, again, raised here, the issue with diabetes, aging population, falling fertility rates. All the regional countries are maybe their statistics are not as much as Singapore, but they'll be catching up with them. So what can they preempt learning from Singapore?
Okay. I mean, that's a tough one. I have to be very careful what I say. So I think in terms of getting the GP, so I can't really offer any advice for other countries, because each of the countries would have a different family practice system. I would presume most of them are private practitioners. That means in the private sector, apart from the government. I only know a few which are actually part of the government, but if you're talking about a system where you have a primary care provided by the government, like in Singapore, the polyclinics, and then in parallel, a primary care system that is provided by a private sector, which I think is in the case for most of the countries, then it really depends on the stage of evolution and how they constructed it in the first place. So for Singapore, the GP committee started decades ago, and really it's grown over time to provide quite a bit of the care more for the acute cases. Right, the polyclinic tends, although they are smaller in numbers, they provide most of the care for the chronic diseases. So the shift has been actually to try to get the GP self-organized, as I mentioned, these primary care networks, to then be better able to take care of the chronic diseases. So I think if you ask me what are some of the things that I could kind of backtrack and share with other countries, maybe to really get the GP community mobilized early and get them on board to help out with the management of the whole gamut of diseases. How might they do that? Possibly through incentive schemes financially for them, possibly through a better kind of a continuing medical education for these people and getting them accredited. Because if you don't tackle that problem, then there's a worry, and it's happened in Singapore, as you well know. A number of our GP clinics actually started to turn towards aesthetics. So rather than doing, really healthcare work, they were doing aesthetics because it was far more profitable to do so, right? So hopefully none of the other countries would follow that bad example, but hopefully be more focused on really giving good care to their patients. But a lot of things really depends on the local country. So all I would say is if I were to say give any inverted commas advice, would be to really engage the GPs early in the discussions about how they would want to be better involved in promoting health, and really because if the GP is in the aspirational state that we are looking for, where the GP and the family has a relationship like the one family doctor for life kind of thing, that kind of relationship can be very powerful, and those people will be very influential in helping people to be influenced to take better care of their own health and so on. So that's just some food for thought. But I can't really give a whole lot of advice in that respect.
No, it's just pointing to things which could be useful, but this actually feeds right into a question posted by earlier by one of our registrants, and that is that we're going back to Singapore. Is empanelment an item to be explored for Singapore's health system, and if so, how should it be applied?
Right. So if you're talking about empanelment of the population to a healthcare institution or to something, I think that's something definitely to think about. I would perhaps just say at this moment that whoever asks a question should tune in to the Ministry of Health's Committee of Supply speech coming up sometime in February, March, and I'll leave it at that.
Oh, okay. That's a nice little, save the date for this answer. Great. Again, someone from the audience asked, how will all this affect nursing home for the aged and sick? So I'm not sure what they mean by all these, but I think just your overview of the way Singapore has developed its health system. So.
Well, nursing homes, I did show a slide that said that the government is going to build 7 more nursing homes and so on. And that's really a problem because we have less and less caregivers. The caregiver ratio to our seniors is getting less and less. And so today we talk about the sandwich generation for people who have to look after their children as well as their aging parents, right? And to be honest, it's a difficult challenge for a lot of people. So nursing homes then becomes a kind of a surrogate way of being able to care for a parent who may have high needs. So I don't think we should kind of stigmatize those people who do have parents in nursing homes. Sometimes it's really to do with the fact that they are unable to physically themselves. The spouse is also frail and aged, for example. So there are many reasons for that. But I think with the aging population, the hope for the government is really, to me, the nursing home building up capacity is, I would posit that it's more a safety net of last resort. Because the preference for the government is really more that we will be able to age in place in the community at home with our loved ones, with some kind of support, monitoring that comes from not necessarily just our immediate family members, but maybe our neighbors, for example, our caregivers, folks like the ambassadors who drop in now and then to check in on them, folks like befrienders who actually go around to make sure that some of the lonely, isolated are taken care of, that the mental health issues are also addressed and so on. So I think the nursing homes is really to me a measure of last resort. The idea and the ideal is really to have our seniors age healthily in their own place of residence.
Yeah, and with the falling fertility rate, all these kind of other support systems need to be there because they're just not, people are not having enough kids to look after them when they're old. So I see we're almost out of time, but maybe the last question, and I know it's a very big question, so you can't kind of wrap it all up, but what would you say about, all these questions are so complex, but how do we make sure that in this complexity, we don't lose focus on the issue of equity and we make sure that all parts of our society, and when I say I mean both Singapore and, for regional countries, the same questions, even if they're at different levels, how does one kind of make sure that you're keeping that focus on equity in your, worldview?
Yeah, so I think this whole issue of access to healthcare is critical. I do believe every government is aware of the need for access to good healthcare, but it's easier said than done. So in terms of being able to access good healthcare, the first thing is for the governments, the policymakers to be very aware that whatever you're doing in your healthcare policies, it's a good idea to look at who are the marginalized. And there will always be marginalized communities in each different countries, and it will be different for different countries, right? For us in Singapore, at one time the marginalized were those old folks living alone at rental flats, for example, right? Who don't have the kind of access to care. Then we moved in with our ambassadors and so on. We moved in to take care of their social needs as together with their healthcare needs and so on. But I think the recognition must be there that there is a need to constantly be looking out for inequity in terms of access to healthcare for your population, because again, as PM Lee said, right, healthcare is also emotive and it is political, because if you have started to have larger and larger communities that are disenfranchised, you're going to lose votes and you're going to have an uprising or whatever it is, right? So I think it's just really for each government to really make a stand very clearly that they do owe their citizens good access to affordable healthcare. And that's something that we've been trying to do, right? It sounds very simple, right? But in the earlier plan that I showed in 2012, we want to have good quality, affordable, and accessible healthcare. And interesting, even in Singapore, we use the word accessible, right? You think in Singapore so small, we wouldn't have to put it in, but we do. We have to put it in. Right? So it's the acknowledgement that it's really something very important.
Right. Okay, great. So we're out of time, but thank you for that great talk. I think if anyone needed a 1 hour catch up on all of Singapore's, healthcare, where it started, what the transfer, different cycles were and where it is now, they got it. So look out for our recording in case you, want to go back and refer to, Edwin's great presentation, or if you need to cram for something. And again, thank you to the audience for being with us. Edwin, thank you for, giving this talk, and look out for our, end of February talk, seminar series talk next month. Thank you all.
Thanks.